Good day. Hi, and welcome to this Daily Maverick Money Sense webinar. Today, I'm your host, Neesa Moodley, editor of Business Maverick, and I'm in conversation today with Zee Gumede, who's a consultant at GDC, and Fazlin Swanepoel, head of AlexForbes Health. And we're going to be talking about a hot topic for this time of year, how to choose your medical scheme. Thank you for joining us, ladies.
Thank you, Neesa, for having us.
So, and welcome to the viewers, of course. So it's that time of year. It comes up every year, and I think even though I write about this topic every kind of like, what do I need to do again? Because every year your medical scheme sends you an letter to say, okay, you're going to either renew or you can change your option, or well, they don't tell you, but you could also change your whole medical scheme, right? And while money is always a big consideration, it's not anywhere close to the whole equation because there's so many other factors that go into this. I think one of the first things is let's chat about your health needs. Fazlin, what am I looking at when I consider changing?
Yeah, no, thanks. I mean, it's an excellent question, and I think it's also a very complex one. I think the first thing for me would be to actually engage an independent financial advisor, and one that isn't really aligned to a specific product itself. And it's their jobs essentially to ensure that they remove some of that complexity for you. And I think the important message around that is that you're not alone in this, and you don't really need to feel that way. But the financial advisor will ensure that your choice actually aligns with both your health needs and your budget through an extensive financial needs analysis. Of course, one of the things that we would need to take into account when looking at which is your appropriate medical scheme is, have you been on a medical scheme before or not? Because that then helps us understand whether there are waiting periods or pre-existing exclusions or some kind of underwriting criteria that we need to take into account. Even something like a late joiner penalty, which is calculated.
You're going really fast. Let's slow it down a little bit.
I can slow it down for you.
Definitely. So you've said a lot already, but you mentioned waiting periods and whether or not I've belonged to a medical scheme before.
Correct.
Let's just unpack. What do you mean? What is a waiting period?
All right. So essentially, there are two different types of underwriting that could be applied to you as a member. And the first being what we call a general waiting period. Now, a general waiting period runs up to a period of 3 months. During this time, a member would essentially pay for premiums, but they don't enjoy any benefits unless it's an emergency or what we call a prescribed minimum benefit, which I'm sure we'll get into a little bit later too as well. And this, of course, depends on a scheme's discretion in terms of how they want to apply that. Then the second one that could be applied is also a condition-specific exclusion. If you have a pre-existing condition, and that exclusion lasts up to 12 months. And it essentially means that the scheme won't cover any treatment related to that particular condition for up to a year. But again, prescribed minimum benefits might still be covered, even if it's a condition that's been excluded from your general benefits. I think the third one that I do...
Sorry, could pregnancy be one of those excluded conditions? So let's say I didn't belong to a medical scheme and I found out I'm pregnant. And now I'm like, oh, sure, but I need to join a medical scheme so I can enjoy some benefits. Does that work? Can I do that?
You could apply, but the medical scheme will reserve the right to exclude that condition for 12 months, as well as apply a general waiting period up to 3 months. What it's there for is really to protect the medical scheme and its members from what we call anti-selection. And that is to only join a medical scheme when you need it. And it's really just there to keep, the system financially sustainable and fair. And I think the important thing as well is consulting a healthcare expert like ourselves, make sure that people aren't unfairly excluded from care. There are conditions where if you are joining under an employer group and an employer deems your membership compulsory as part of the employment policy. In a situation like that, if somebody joins an organization that has a policy like that, we can apply to the medical scheme because it's compulsory, and therefore, under that status or policy conditions, effectively a medical scheme would have to accept you without underwriting. So it would depend on a whole host of that criteria. We'd have to take into account all of those aspects when advising you on underwriting. There is a third thing that I just need to touch on.
Sorry, it's so we've all got to get a chance to chat. So Zee, I think Fazlin touched on late joiner penalties and whether or not you've belonged to a medical scheme before. So can we maybe just unpack for the viewers what is a late joiner penalty? What qualifies as late joining, and how much would I expect to pay in penalties?
Okay, thank you very much, Neesa, and thank you, Fazlin, for that information. It's important to note that a late joiner penalty fee forms part of the underwriting that can come with the 3 months general waiting period and or the 12 months condition-specific waiting period. And I'm glad you raised this because the late joiner penalty fee is the most lethal. Because if you think about the waiting periods, they over a specific period and then they over, But with a late joiner penalty fee, it can be for life. And Fazlin raised a very important point when she says, if you're joining as part of an employer group, take advantage of that because you could have your late joiner penalty fee waived. But if you're joining as a private client, you find that it is going to be based on your current age. So the scheme that you're joining wants to protect the current community of members that have been contributing towards this particular medical aid scheme or society. Right? Now, we all know that we age a year each year, whether we want to or not, whether we celebrate it or not. And when we age each year, something happens with our health. I don't want to say it deteriorates, but there are changes that we have to embrace. And so what happens is that we start to claim for things that we never claimed before, that we didn't need before in our 20s. So the scheme looks at your current age to say, how old are you? And they use a benchmark age, which is regulated of 35 years of age. And so if, for example, I am 50 years old right now, that is my current age, the formula that you would use is you take your current age, subtract the benchmark age of 35. Okay, now that in this particular example, it leaves me with 15 years. All right. The scheme says to you when you complete your application form, show us that you've at least had creditable cover on a South African accredited medical aid scheme in previous years, be it as a dependent or even as a principal member. This is when you will complete on the form or provide membership certificates to say, during this 15 years that I'm trying to prove I had cover, I was on this particular medical aid scheme from this year to that year, this one from that year to that year. Now say altogether, I only had 10 years, right? Altogether. They're going to say the difference, which is 15 years, subtract the 10 years which I had, which leaves a difference of 5 years. And then they have a table that they use that ranges from 0 to 4 years, 5 years to the next level, and so forth. And every level has its own percentage, and it goes from 5% all the way up to 75% penalty fee, which you could find yourself paying over and above your risk contribution that you pay to your medical aid scheme. So the advice would be
added every month.
Correct.
To my risk contribution.
That's spot on for the rest of your life. And so the advice would be try to join medical aid before you turn 35 years of age, or make sure that at least you've had creditable cover on other accredited medical aid scheme, be it as a dependent or as a main member.
Does medical insurance count?
Medical insurance does not count, unfortunately, because medical insurance is regulated as a short-term risk short-term risk insurance policy, right? It's not regulated under the Medical Schemes Act 131 of 1998. And so the rules that they apply are different to the rules that are applied by a medical aid scheme. They also have waiting periods, but they don't have a late joiner penalty fee.
Right. And then Fazlin, so we touched on late joiner penalties and one thing at a time, but how do I even start as a layperson? I mean, you and Zee, clearly, this is what you work for, right? This is your bread and butter. You know medical schemes inside out. But there's 71 of them out there. And even though not all of them are open, it's still quite a lot. So how do I even start comparing when different schemes have like 10 different plan options and then different names and then different benefits? How do I compare? What am I looking at?
Yeah, look, I mean, I think as I alluded to earlier, consult an expert. But in the absence of that, there's a number of things that you need to consider when looking at an appropriate medical scheme. In our environment, what we would ordinarily do is we would perform what we call a due diligence on every single of those 72 medical schemes that you refer to. And out of that, we've got a matrix that takes a whole lot of criteria into account. Things like growth, financial metrics, things like average pensioner ratio, etc. So three key things: financial strength, good governance, and obviously real member value. So in the case of a medical scheme, we would want that medical scheme to have an adequate number of health reserves. Legislation requires it to have at least 25%. That means that there is the ability for that medical scheme to be able to pay a run on claims if it's going through some very tough years. The second would be strong governance and risk management, which is very key. So we look at things like ethical decision-making, responsible benefit design, and just how they've consistently kept up against the needs or changing needs of a member. And then finally, obviously, the most sustainable medical schemes often are the ones that deliver real value to our members. So we look at affordable contributions, consistent service, the extent and quality and reach of their provider networks. Do they offer any preventative wellness programs? Because ultimately we want to make sure that they're attracting young and healthy people, so that the risk is effectively managed. So we would then, from that 72, running that entire metric, come up with a metric that says these are the top medical schemes or 8 medical schemes in the industry. We would then further break that down once we've done your needs analysis, which takes far more complexities into account. And this is where we have a conversation with you. What has your medical scheme usage been like over the past year? As an example, do you anticipate your current life-changing or your current circumstances to change in the year ahead? Are you planning a family? Have you recently been diagnosed with a particular chronic condition? We then ask you about where you live and the lifestyle that you lead. That's critically important in certain network options. For example, are you based close to a particular medical scheme's network? Are you going to get the coverage that you need?
So how does the network work?
So every medical scheme will approach a certain group of service providers. Those are doctors, dentists, specialists, any form of speciality that you can think of. They will contract with that particular doctor and negotiate with him or her to charge a particular rate. And in exchange for complying with certain conditions that they set in their contract, the doctor then agrees to participate in that particular network. That then means if a member is based on a network plan, they then allowed to, or whichever plan, they would be allowed to access that network.
So even hospitals?
Those include hospitals as well. So every single medical scheme that has a particular network option will drive members because of cost management, containment to particular networks. But those are not on every single plan. It's very specific network plans, yes.
And then when it comes to network plans, because it's a specified list of providers or hospitals, how do I access it? Can I find out from the scheme beforehand who their network is so that I can do research on whether it's actually convenient for me or accessible for me? I mean, I don't want to choose a network option and then find out that I've got to drive 2 hours to access the nearest network hospital.
Yeah. Absolutely, Neesa. When we perform the financial needs analysis, we will go through that process and look at whether a network option would actually suit you of a particular medical scheme, because you're based in the proximity of those particular service providers. Every medical scheme publishes their networks on their medical scheme website. A lot of them are moving towards digital channels now as well, where you could, for example, WhatsApp a particular medical scheme, and they will respond and inform you whether a doctor is on your particular network. The third option would be you can contact your medical scheme or your advisor, and they'll be able to advise you accordingly as to whether that is a network hospital. Sometimes when you are pre-authorizing for a planned hospital event, they will advise you upfront that is a network hospital if it's relevant to your plan, or you are going outside of the network, you therefore will experience a particular co-payment. So that potential could also exist.
Sorry, that was my next question. So if there's a situation where I have to, for whatever reason, use something outside of the network, I can do it. I'm going to pay a penalty or a higher cost.
Neesa, that would come down to the plan option on that particular medical scheme that you're on. Hypothetically, if you have selected a network option that dictates you have to go to a specific network, if you go outside of that network, you are most likely going to experience what we call an upfront co-payment. So in hospital, before you go into a hospital and at that desk where you're registering and saying, I'm about to have my procedure, in fact, before that, when you pre-authorize already, the medical scheme will say to you, this is the expected co-payment. When you get to that desk, the hospital will ask you to pay that. And I guess that's where it's so critically important. I don't even want to go there just yet, but if you have gap cover, then it's also important to understand whether your gap cover will cover that co-payment out of network.
So talking about gap cover, Zee, and hospitalization, let's just touch on, what does it mean for me when I go to hospital and I get a bill or I get a statement from the medical scheme talking about 100%, 200%, 300%. What does that even mean?
All right. Thank you so much for that question. And thank you, Fazlin, as well, for laying the foundation to this. Well, when you start talking about gap insurance, you need to understand that in South Africa, GPs and specialists are not regulated. In other words, you have the Council for Medical Schemes that regulates South African registered accredited medical aid schemes, but you do not have a statutory body that is regulating, for example, your GPs, your specialists, your hospitals, the price of medication. So in other words, it means that medical aid schemes have to go out and create networks and talk to different service providers and request them to charge at certain levels, etc. The medical aid scheme is regulated and therefore it pays out at the medical aid rate. Okay, the GPs and specialists are not regulated, so they can charge you anything that they want to charge you. What that has done is it created a gap between what your doctor is asking you for and what the medical aid is paying out. So finance firms decided, you know what, there is an opportunity, create gap insurance to fill in the gap between what you're being asked for and what you've bought into. Because we need to remember that medical aid, as much as it is about your life and you feel everything must be covered at cost and unlimited, it is still a financial product. And so there are benefits that they will cover up to a certain point, and some where they will cover you unlimited. Your prescribed minimum benefits, you do not need to worry much about that because the CMS has protected you in that regard. But for your planned procedures, when you're going into hospital for a planned procedure, you need to ask the question, okay, what is my cover? Am I covered at 100% of the medical aid rate? Because the mistake that we make as members is when we see 100%, we immediately think at cost, and it's not. It's at the medical aid rate. Some options cover you at the medical aid rate, which is 100% of the medical aid rate. Some cover you at 200% of the medical aid rate, which is double the medical aid rate, and some 3 times the medical aid rate, because medical aid schemes had to understand that some providers do ask for 3 times their level of cover, which is the reason why they give members those options. And so gap insurance comes in where they can even give you 5 times the medical aid rate additional on top of the cover that you have, sometimes 4 times, sometimes 3 times. So the shortfall part that gap covers is intended to cover what your GP or your specialist requests from you when you've been admitted in hospital. And another misconception is people tend to think that gap insurance is there for day-to-day benefits. It is not. It was created for in-hospital procedures because those are your most expensive ones. And that's where the insurance wants to reassure you and make sure that you've got that extra cover when you need it. And then they take it a step further, Neesa. They say not only will they cover shortfalls for the GPs and specialists, but they'll also cover co-payments, because sometimes when you go into hospital for certain procedures like your MRI scans, CT scans, and scopes, you're required to make an upfront payment to the hospital. Now, in the case of co-payments, it can be taken out of your medical savings account if you're on a new generation type plan. But if you are a member on a hospital type plan, you'd have to pay that out of your pocket. And that's where gap insurance comes in. That way you're able to claim it back from the gap insurance provider.
Thanks. So we've got a lot of audience questions coming through. We've got to start rolling through those. Catherine has a good question. She wants to know, is it true that with medical schemes, the way they have a savings component, if you compare it to a hospital plan, that RAND contribution difference is basically the savings component? And then using that logic, why would you not just use a hospital plan, which is cheaper, and take that extra money and put it into a savings account on your own?
Okay, that's a very good question. When you actually do the calculations, you will find that not only are you paying for the savings that you're receiving, which is why it's called your money, right? You're also paying an administration fee over and above that. So it's actually a bit more than the medical savings that you're actually paying back. The whole point of the medical savings account, the benefit is that you're receiving it upfront. So it works as credit, because on the 1st of January or on the 1st of the month that you are starting that particular membership, you receive all your savings in one go. And it is up to you as a member to manage your medical savings account throughout the year. So our pockets are different as members. Some people have that money up front and they're able to take a hospital plan and take care of their own day-to-day. While in other instances, some people need that credit. They need that money to start off the year and to access those benefits.
Sorry, I just want to say it's not payment upfront. It's money that's available to you immediately at the beginning of the year.
That is
it's
correct.
Not paid to, I just want to clarify for anybody listening thinking they're going to get a big payout in January.
Oh, no. Yes, so it's incorporated into the option that you're on. If it has a medical savings component, that money will be put into that component, which you then use for day-to-day benefits, and you receive it at the beginning of the year in respect of the whole year, and you must manage it for the year.
And then Fazlin, Carl wants to know, is it, sorry?
Apologies, I just wanted to add something to that, which is a very important component of the medical savings account. It's a privilege to get that money up front into this vehicle, but also just bear in mind that if you are going to resign from a medical scheme before the year is up, there is what we call a potential clawback. It's just important for members to know that. So even if you leave a medical scheme, you are required to pay that clawback back. Right.
That's
Thanks,
a
Neesa.
very good point. I think a lot of people forget about that because typically the medical scheme wants you to switch now in January at the beginning of the year, but you can switch at other times of the year if you change employers or whatever it is. But Fazlin, Carl asked a question that maybe you can help us with, where he wants to know, is it better to join a scheme that is self-administered or one that is administered by a third party? Is there a difference between those two options?
Yeah, there is essentially a key difference. I think what you'll find is that self-administered medical schemes are often able to reduce their costs a little bit more in terms of their non-healthcare expenditure, as opposed to an administered medical scheme where a third party needs to be paid in order to administer that medical scheme. So that sometimes is the subtle difference that we will see in the non-healthcare expenditure costs when comparing those two. But insofar as the actual administration or experiencing that service is concerned, there shouldn't really be a difference. It comes down to the quality of the administration, and you often will feel that in the service that's being delivered to you as a member.
And then Cindy says, and we're seeing apparently more questions coming through or comments coming through in this vein, not specifically about choosing a medical scheme, but she's on a medical scheme. She's using a specific option, which is not just a hospital plan, and she uses hearing aids. And apparently the medical scheme has never paid for the hearing aids. She's had to use what was in her medical savings account to buy secondhand hearing aids, which, by the way, for those of you who don't know, are incredibly expensive, I have learned. But Fazlin, how do you, is there anything she can do? Does she have to shop around to a different medical scheme? Can she ask an audiologist to write a motivating letter to the medical scheme?
Neesa, I think it's important to understand what constitutes in-hospital expenditure and out-of-hospital expenditure. In-hospital expenditure, or what we call risk benefits, is often your hospitalization, your chronic benefits. Those are things that come out of your hospital benefit. Out of hospital is anything that doesn't take place, as it says, in hospital. And hearing aids, unfortunately, is one of those that we call external surgical appliances or external appliances. And those are deemed expenses that are covered out of a medical savings account or your day-to-day benefits. If somebody is on a traditional option, which is a stated set of benefits, so in other words, a medical scheme that is a traditional one will say, you have this basket of benefits. For hearing aids, you've got 10,000 Rand a year. For optometry, you've got 5,000 Rand a year, as opposed to a medical savings account where you're given this total amount to use as you see fit. So in this case, it's absolutely correct. It will probably be dependent on the type of plan she's on, which sounds like it's a new generation option with a medical savings account. And therefore, the external appliance or the hearing aid will come out of a medical savings account.
Zee, if you're happy to move forward, I think David's got an interesting question. So let's say I've been on a medical scheme plan. It's been Coastal Saver or comprehensive or whatever you may have. And now I want to switch to a hospital plan, but I'm also using chronic medication. What happens?
Thank you very much for that question, David. So you would need to first ascertain what is your chronic condition. Once we know what your chronic condition is, then we would need to look to see, is your chronic condition covered as part of the 27 chronic conditions which are seen as prescribed minimum benefits, which have to be covered on all South African medical aid options? Or is your chronic condition one that is covered on the comprehensive range of benefits that you'd find on medical aid schemes where they cover 60 or more, any additional types of conditions? So the question would be, what is the condition? And secondly, is the condition a prescribed minimum benefit or not? And if it is not, how much are you spending or how much is the medical aid paying for you for that specific chronic treatment monthly? And so if I were to move from that comprehensive option that covers that particular treatment and I moved to a hospital plan, how much would I be paying for myself? And so when I subtract the difference in contributions to the treatment, that will tell me whether I should actually be downgrading or not downgrading.
And then you touched on prescribed minimum benefits, and Fazlin also mentioned it a little bit earlier. Fazlin, let's just what are prescribed minimum benefits, and how do I know whether my condition or medication falls in that bracket?
Yeah, so in South Africa, medical schemes are required by law to provide certain minimum levels of cover, and this is what we call prescribed minimum benefits, or some people refer to it in short, PMBs. I'm sure you've heard about that. These include about 271 prescribed minimum benefit conditions. It's everything ranging from medical emergencies to what Zee spoke about earlier, which is the 27 chronic conditions. These are conditions that require ongoing and regular treatment or medication specifically. For example, diabetes, hypertension, asthma. But for PMB conditions in particular, a scheme must pay for all your consultations, your tests, your medication in full, as long as you are using their designated service provider and follow their treatment protocols and guidelines. Right. Yes, beyond that, some schemes do offer, as Zee alluded to, additional chronic conditions which are not necessarily on the prescribed minimum benefit list. And this is what we call additional diseases. And this is optional, and it does differ by plan. So in short, PMBs are like what we call a legal safety net that guarantee essential care and, in terms of chronic benefits per se. It's important to note that they do get reviewed from time to time. Currently, I know that there are two areas in particular, mental health right now and primary healthcare benefits, which are undergoing a review. The important thing is to go onto the medical scheme's website or consult your advisor, or you could, I don't want to say chat GPT, because, but it is channels that people are using these days. You can go on there or you can contact your medical scheme and just find out whether your particular condition is a prescribed minimum benefit. And whether your chronic condition falls within the 27 prescribed minimum benefit chronic conditions, or whether it falls within that additional chronic conditions. That often is a critical component when we are advising you on which medical scheme, option, or plan to choose. That's going to be, that's going to work specifically for you.
And I think just important to note also on the PMBs, if it is a PMB condition or medication, it doesn't actually come out of your medical aid savings account. It's separate to that. It comes out of the medical scheme risk pool rather than your savings.
That is correct.
Yeah. And then Zee, Margaret wants to know, is the only benefit, I don't know if that's the wording I would use, is the only benefit of the savings account versus a hospital plan the fact that the total year savings is available at the beginning of the year? Maybe let's just dive into how you would use those savings.
Okay, so how you would thank you for the question, Margaret. How you would use the savings is for your day-to-day benefits. And by day-to-day benefits, we're talking benefits such as GP consultations, specialist consultations, over-the-counter medication, the services that you would require if you're not admitted in hospital. For example, optometry, dentistry, x-rays, and blood tests. And that's why it's so important to manage your medical savings account. Now, it doesn't necessarily mean that if you remove the medical savings account, the level of hospital cover would be the same across the board, because there are different levels of hospital cover. Right. Remember, we spoke about the percentages, the 100%, 200%, 300%. So in that particular case, as a member, if you were to choose a hospital plan, you would need to choose a hospital plan that is at the level that you are looking to be covered at. Whereas a person who's choosing a plan with a medical savings account also has the option to choose the hospital level that they also want. I don't know if I'm making sense, but just to answer what she's asking, it is important to note that the medical savings account covers for day-to-day benefits. Hospital cover, which is risk, comes from your risk benefits, but the level of hospitalization does not necessarily mean it's going to be the same if you drop your medical savings account and move on to a hospital plan, because there are different levels of cover on a hospital plan as well.
Exactly. Barbara has a question, which I am going to read out. She says, do all medical schemes offer gap cover, even closed medical schemes? And she's got a gap cover question. So Barbara, the medical scheme doesn't offer the gap cover. The gap cover is a separate financial product you buy from an insurer, and it's a completely different company usually. There is some confusion because there are some providers where the umbrella company has the same name, but it's not the same. It's not the medical scheme offering the gap cover. And I think we should and will have a separate webinar just on gap cover because there's so much to talk about in that space.
Neesa,
and then,
can I just add
yes.
something? Apologies, just something for that, just related to that. Some medical schemes are registered in both long-term and short-term, so some of them do offer gap cover. But you're absolutely correct. Absolutely correct. It sits in a separate entity, which is the short-term insurance entity and not the long-term insurance entity. So some do absolutely offer, gap cover, which I think why the question,
the confusion,
yes, or the confusion, yes.
In addition to that, sorry, Neesa, is that even those that do offer gap insurance under, the umbrella, do still give you a waiting period. And that's the interesting thing. So a lot of members think, okay, if I'm with this particular medical aid and I join their gap insurance, I may not have waiting periods. Please note that you would still experience waiting periods there as well. And what we found when we do our comparisons and reviews is that those that do offer gap insurance over and above the medical aid, when it comes to the level of benefits that they actually offer, it is not as competitive as if you were using a gap insurance provider that was not associated or linked to your medical aid scheme. You will actually find that those that are not associated actually pay for more, because if, for example, I am a medical aid scheme and I've got a gap insurance and I cover you for penalty payments, even though you've asked to be on an option that's restricted, then it means it's counterproductive. It doesn't make sense. But if you, for example, choose to be on a different gap insurance and there's a penalty fee on your medical aid, you will find that you will have cover for that. So it's very important that you do a review on gap insurance, the same way you would do a review with the medical aid option to see what level of cover are you looking for, and of course your affordability as well. And last thing is age, because with gap insurance your age matters, whereas with medical aid your age matters when it comes to the late joiner penalty fee. With gap insurance, so there's something called open enrollment on medical aid schemes. You cannot discriminate based on age and health, so everybody pays the same when it comes to a medical aid contribution. But when it comes to a premium on gap insurance, you will find that if you're above maybe the age of 60, some say 64, some say 65, you would pay more than someone who is below the age of 60. Thank you.
Okay, and then Fazlin, I'm going to hand this one to you. It's a very relevant question in today's society with blended families. Catherine wants to know, so she and her son are on their own medical scheme. They've got their membership, and her husband is on his medical scheme, which is separate, but the same plan actually, and the same medical scheme. What are the pros and cons to all being on one plan as opposed to keeping it separate?
I think we would need to understand why there's a separate membership. Often it's driven by an employer policy, which dictates that, or it's been two separate families that have now come together.
Exactly.
So it would depend on the reasons as to why they are separated. For example, if somebody is joining an employer associated medical scheme, there may be a subsidy that they provide for a principal member only. And that could be driving the decision as to why that individual is on that particular medical scheme. We find that 99% of people will stay on an employer-based medical scheme because of the benefits of being there, financial benefits, potentially. All things being equal, if there is no employer subsidy or no policy that's driving this, there's absolutely no reason why we cannot blend that family onto one particular policy. You're reducing administration fees as a result of that. It's far easier to administer your medical scheme, and it just reduces, I think, the administration complexity for you. You then get access to a completely different range of medical savings accounts or traditional benefits, depending on your option, because it's based on family size or composition. And we would need to look at whether cost and value makes sense, in particular in that. It will come down to us performing a very stringent financial needs analysis based on their particular circumstances. So it is conversational. I'd need to understand a little bit more before I advise that member. Yeah.
Absolutely. Zee, is there anything you want to add on that one?
Like Fazlin says, it would be very important for us to find out what their healthcare needs are, for example. You could find that perhaps there's somebody in the family, I would want to know, how old are they? In terms of the children dependents, how old are they? Are they turning 21 anytime soon? Because there could be an adult dependent rate that's about to creep in. How old are the parents? Are they nearing retirement or not? What is the life stage that they're at, in order for us to be able to ascertain whether they should be all together or not. And healthcare needs, of course, are very important, and as much as affordability is as well. We would definitely need more information from them to be able to say, should they be together or should they remain separate?
Okay, and then we've got Alethea, I hope I pronounced that right, wanting to know, is there an age where it makes sense to pay more for a higher benefit plan?
It would depend. Yeah. Oh, sorry.
Yeah, please go, Zee. Yeah.
Oh, thank you, Fazlin, and thank you, Neesa. I think it's not necessarily based on your age. It depends on how is your health at that particular age, right? At that particular point in time. So one would need to look at, okay, so what am I struggling with, or what do I suspect I may have, or what have I been diagnosed with? Because you find 65-year-olds that are healthier than a 25-year-old, right? So just because I'm older does not mean that I should be paying more. And so that's the reason why practicing King 3 is so important at this time of the year, because you want to ascertain whether you're overinsured or underinsured, despite your age. So for me, I would look more at what are my healthcare needs, as opposed to what is my age, and also what is my affordability, and where am I in the stage of life, for me to determine which option should I be on, or should I be paying more, or should I be paying less? That's where I would begin.
Okay. So we've got a question. I think it's important to point out, as both Fazlin and Zee have quite rightly said, individual advice would have to be tailored to your specific circumstances. So it's very difficult for them to try to answer those questions. Having said that, we'll take a stab at something which came through from Diane, because it's an interesting one. She says she's 70 years old, she's retired. It's 3 people in the family. They've been on a plan that has a medical savings account, but the medical savings are running out every year in March.
Oh,
That's really quick, Diane. Wow. Her degree means that they qualify for ProfMed, and she can move the whole family over to ProfMed. What are the consequences of her doing so?
Would you like to take that,
potential consequences?
Perhaps I can touch on just some of the red flags, that tell us often that you should be considering a medical scheme change. And I urge you to seriously go through that process with yourself, because sometimes it's not as simple as just cost and etc. So things like if you're constantly paying co-payments out of your pockets, you're hitting your benefit limits early in a particular benefit year. Those are some of the flags. Another warning sign would be if your chronic medication or regular treatments aren't fully covered. Your preferred doctor or hospital isn't in the network. Sometimes this plan just feels a little bit too basic for your particular needs, or it just feels too rich for actually what you're using. Then we would honestly say that potentially there could be a red flag that says, let's look at your benefit option. Life-changing circumstances are critical to consider, such as marriage, having kids. Have you recently been diagnosed with a critical illness? Have you lost your job and can no longer afford such an expensive medical scheme, but you've got chronic conditions and costs to consider? A change in affordability. These are all triggers, I think, that warrants a need for us to review whether you should be considering a change in plan. I think finally, and only finally, if the premiums of that particular medical scheme just keep rising from time to time, you're experiencing very bad service. And in other words, basically, your plan is costing more than you actually receiving. Yes, I would then encourage. I'm a little bit hesitant, to give advice, to this particular member in that case. Again, we would need to go through her specific circumstances and have a conversation.
Absolutely.
Zee, I don't know if you want to add something.
Well, in that particular case, Faz, I agree with you completely. The review is definitely important. And when you talk about red flags, it's important for one to look at the type of year that you've had currently. If you're already a member of a medical aid scheme, what did you experience? And they're mentioning that they're running out of day-to-day benefits at the beginning of the year in the first quarter already. That is a red flag, a big one. And so you have to ask yourself, okay, because I ran out of day-to-day benefits at that point in time, is it necessary for me to upgrade, or should I be looking for a health insurance product that can complement my day-to-day benefits? Request a claims transaction history from your medical aid scheme, because we sometimes forget, what did we actually use our medical aid on at the beginning of the year? Because we come to October and we're like, it's already finished. I don't know what happened. When you get that claims transaction history, it will give you the date, it will give you the name of the provider. It will also tell you how much did you actually spend on that specific provider. So you're able to see, am I spending a lot on the pharmacy? Did it all go perhaps to optometry? And I mean, I only do that once every 2 years. So next year, it means it won't be happening again. Or did I experience any exclusions? Are there any elective procedures that I needed to go in for? And I was told, sorry, but elective back and neck surgeries are not covered on your option. Do I actually need to look at gap insurance cover to complement the actual cover that I already have, or should I be upgrading? And so when you do those calculations and you look at what benefits am I getting from this complementary product, which I must mention, please note, there may or may not be waiting periods. Most probably there will be waiting periods when you take gap insurance or you take health insurance to complement your medical aid. But instead of always looking at upgrading, the question is, how much does it cost my family from a contributions perspective to move from this level to the next level, as opposed to taking out 2 different covers just to complement my medical aid cover, as opposed to having a bigger contribution increase in the new year?
Neesa, I do just need to stress, there's a key statistic that we find as advisors. Often when somebody says to us, I think I'm on the wrong medical scheme, sometimes when we assess the situation, we find that it all comes down to the individual not really understanding their benefits and how to access those benefits. So I do just want to stress the importance of educating yourself around the workings of your particular medical scheme, because that sometimes can create a little bit of the frustration that you feel. And just a little bit of understanding and education you could find yourself being able to access a lot more benefits because you understand it a little bit better.
I agree completely with Fazlin, Neesa, because what you find sometimes is you have a condition that you actually haven't registered with the scheme. And registration of a prescribed minimum benefit is not automatic. You have to go through the scheme's registration processes to have it loaded in order for it to pay from risk and not from your day-to-day benefits. Now, if I have diabetes and I haven't registered it and I go to the pharmacy every month with my script and I get my diabetes medication, it's coming out of my day-to-day. Meanwhile, had I registered it, it could have actually come out of my risk contribution because it is a prescribed minimum benefit. The other thing is monetizing your healthy habits. I mean, we've got exciting things happening with the loyalty programs, and some are not even loyalty programs. It's just a rewards program where you don't even have to pay extra. Next year, some schemes are rewarding you for sleeping. For so many years, we used to say, oh my goodness, they expect us to go to the gym and to do this. Not all of us are active people. Well, there we go. You're being rewarded for sleeping well, and so I'm just saying to members, find ways to use your benefits that are already there, as Fazlin correctly put it, and you'll find that you will just have to do a screening just to activate a booster, as an example, and that gets paid from your risk. So it's very important that you look at what you currently have. Thank you.
So Samantha, actually Zee, in her previous response, she already answered, she preempted your question, Samantha. Samantha wanted to know, what is the best way to calculate the value you're getting out of the scheme versus the contributions you're paying? And I think Zee did quite a good job of explaining that. There will be a follow-up article coming on the back of this webinar, so it will all be laid out there in the article for you to go back and refer to. We're running out of time, guys. It's 10 minutes. I can't believe it. It feels like we have barely scratched the surface. There's so much. And Zee, you again preempted me because I wanted to say loyalty programs. Oh my gosh, like the gym benefits. And then there's these, and if you go to gym this many times a week, you get these vouchers and you can get smoothies. And I think for the younger people among us, unfortunately, I don't think I'm in that category anymore, but these benefits are really very attractive. So what am I looking for when I'm considering different medical schemes? And now the loyalty programs coming into it.
Well, you've got medical aid schemes that will give you rewards where you don't necessarily have to join a loyalty program and pay extra for it, but you would need to register yourself so that you become part of that particular rewards program. And there will be certain things that you would need to do in order for you to qualify, for you to receive certain benefits from these particular programs. For example, the biggest medical aid scheme in South Africa, they have one where they're saying activate this particular program at no cost at all. Using AI tools, they're able to say, this is what we think you need to go for the screening. And by going for that screening and they receive that claim, sometimes you're the one responsible for it. Sometimes it's just an online assessment, which doesn't cost money. But at the end of the day, you get rewarded for that. You've got another medical aid scheme that says, go for your screenings, which is your blood pressure, cholesterol, glucose, body mass index. HIV is optional, and you go to a Clicks or a Dis-Chem, and by so doing, they then unlock a booster, which is extra money that you then use for your day-to-day benefits. Then you've got your loyalty programs that you actually pay extra for. And when you pay, and usually based on your family size, if you're an individual member, you pay less. The bigger the family, the more you pay. And then they have different business providers that they have negotiated perhaps discounts with, and by becoming a loyalty program member and paying that extra, you're then able to access those benefits and services, and they will range in different compartments. For example, movies, you've got your park runs and your park walks, you've got golfing, you've got travel. So they try and give everybody a bit of something to enjoy from being part of those. You also get your discounts at your retail stores, but all of this needs to be activated first. Yes.
Activated and registration, and I'm hearing registration more than once from Zee. Fazlin, when it comes to the PMDs, and Zee had a very good point, the even if you have like a diabetes or asthma, I think the misperception out there is that, okay, your medical scheme knows this is asthma medication and surely this is automatically going to happen, that you're going to be reimbursed at a PMD rate, but that's not the case. What do I need to register for a PMD or chronic condition? And what's this ICD-10 code that where I get to the pharmacy and they're like, no, it's the wrong ICD-10. And I'm like, huh?
Yeah, you're absolutely correct. I think the registration process will vary by medical scheme, and each of them will have an application form that you would need to complete in order to do that. Because we're moving into the digital space, some of these medical schemes are now allowing you to do a lot of this online or using your cell phone. They have chatbots that can assist you if you just send through a question and they'll reply to you. But yes, it is so that the medical scheme is actually aware that you are applying for a particular benefit. And this is the benefit that you're applying for, so that they can load on the system exactly what it is that you are entitled to. To come to your ICD-10, these are what we call procedure codes. And there are hundreds and thousands of ICD-10 codes out there. I'm sure anybody who has had a particular procedure or been to the pharmacy, when you look at your claim, you'll see that it will have a particular ICD-10 code. Think about it this way. There are many variants of particular medications, and each of them have unique ingredients within that particular medication. Each of them will have an associated different procedure or ICD-10 code. It'll tell the provider, just by punching in that ICD-10 code, what procedure you're having done, all the associated little extras or additionals that are associated with that particular code also needs to be provided, and each medication group as well. So it really determines what it is that you're having done and what benefits you are entitled to and how much that scheme rate is for that particular associated ICD-10 code.
I think a valuable lesson I learned a few years ago was, so I have an artificial heart valve and I am on warfarin, and that means it's a blood thinning medication, and that means I have to go for regular blood tests. So off I went to the PathCare lab and they said to me, this is your ICD-10 code, which will pay, that means the scheme will pay for the blood tests and everything related to the condition. So I thought, great. I went to the pharmacy to get my warfarin. I said, this is the ICD-10 code. And then I found out it's a different code for the medication. It's a different code for the blood test, even though it's one condition. So very interesting technical.
You're absolutely correct.
Mm.
Yeah. So when you are pre-authorizing for a particular hospital or planned event, the medical scheme will ask you to provide, or your doctor, in fact, will provide you with all of those procedure codes and ICD-10 codes. That will then be utilized for the medical scheme to determine whether your benefits or the plan that you have will cover you for those particular procedures. Even prescribed minimum benefits have associated particular procedure codes. And so this is critically important to be able to access the correct benefits.
And does the doctor play a role in that registration process? See?
The registration process in terms of when you register in your chronic condition? Yes, indeed.
Does the doctor?
Oh, Very good question. Yes, they definitely do. The ICD-10 code is a diagnostic code. So when a medical professional looks at the ICD-10 code, immediately they know what the condition is, right? And then the procedure codes stand for what the doctor wants to do to you. For example, 0109 would be a consultation fee, okay? So if you've got 0200, you know materials were used and there was medication involved in there. So it's language codes that they use, that they understand. So when you're registering your chronic condition, for the scheme to know what your condition is, the doctor needs to tell you what your diagnostic code is, which is the ICD-10 code. And then they would put that on the application form. They'd also then attach a prescription that says this is the treatment that they want you to take. If you're struggling with hypertension, as an example, they can even prescribe that you need a blood pressure monitoring machine, everything related to that specific condition that the doctor has diagnosed with would need to be registered in order for the scheme to come back with a funding decision letter and to tell you how they would be covering the treatment that is being requested by the doctor. And if anything is rejected, the scheme will tell you why they are rejecting and what it is they need to review that particular decision.
And then we haven't had a chance to get through all the questions. What we will do is I'll try, we have them on record, and I will try and answer them in the article that we produce afterwards. Sorry about that, Anthony. Our webinar coordinator is giving me red flags here that we're running out of time. There is one last question that I think I can answer. He wants to know, can my partner join my medical plan? Do we need to be married? The answer is no. As long as you're in a long-term relationship, more than 6 months, it's considered a permanent relationship and that person is treated as your spouse. And I was very happy to discover even my stepson in this case is able to be added on my medical scheme.
With marriage, Neesa, there is an advantage because if you do it within a certain time period, then it means that they'll come on without any underwriting. If it's just a partner, not due to marriage, then the scheme reserves the right to impose underwriting.
Ah, so there's a waiting period potentially.
There could be.
Potentially.
So is the waiting period versus the marriage? I don't know.
Hard decisions to be made.
Tough calls. Thank
Yes.
you both so much for joining us. I think we're definitely going to have you back. There's so much. I feel like we could do separate webinars just on chronic meds, on PMBs, on hospitalization. There's just so much information and a lot of questions definitely from readers. So thank you very much, Fazlin and Zee, and thank you to the listeners for engaging and being such an active audience today.
Thank you.
You're
very
absolutely
much,
most welcome. Yeah, thank you for the opportunity.
Yeah, definitely. Thank you.